Well, good afternoon again. Thank you, Dr. Pravan and Dr. Sanjay, for inviting me here. And my talk is newer technologies for assessing biomechanics in diabetic patients. The effect of diabetes on biomechanical function was well outlined by the 2020 paper by Laporetz et al. It noted how diabetes can alter collagen, change muscle strength, cause soft tissue thickening, and eventually result in contractions and deformities. The changing biomechanical function of these structures leads to modifications of the patient's gait, diminished postural stability, and increased sway, leading to increased loading on forces of the plantar foot. In combination with neurological and circulatory changes, this places the foot at high risk of ulceration. While investigating diabetic foot ulcers, Professor Paul Brand realised the significance of biomechanics in formation and the treatment of ulcers. In his masterclass in diabetic foot biomechanics, he noted the problem of ulceration will be finally conquered only when it is realised that the damage to the foot is not only a problem of medicine, it is a problem of mechanics. The key question is then, how do we best measure and analyse biomechanics in the diabetic foot? I will focus on some exciting developments in measurement of shear forces that have occurred over the last few years. Also, the development of automation in plantar pressure measurements and spatiotemporal parameters, making the analysis of these parameters quicker and more easily understood by the clinician in their day-to-day practice. These technologies not only assist biomechanical assessment, but also help us better understand the ramifications to our patients, design preventative treatment strategies, improve limb salvage rates, and ultimately provide the best quality of life possible for our patients. The importance of shear forces applied to the foot has been reported by Yevas et al. In several research papers as early as 2007. The main findings are that shear stress is significantly higher in patients with diabetic neuropathy. Shear applies in opposite directions during a single step, which may accelerate tissue breakdown via fatigue failure. Peak shear and peak pressure occur at different locations under the same foot, and application of shear increases tissue temperatures, which further accelerate tissue breakdown. So the ability of measuring shear in a clinical setting is as vital as it is urgent. The first of 3 studies on measuring shear forces affecting the plantar surfaces of the foot is a 2021 paper by Taraz et al. They note particular areas under the foot such as heel, midfoot, 1st and 5th MTP joints and hallux IPJ as the key points for plantar and shear monitoring. They proposed and developed optic fibre sensors containing fibre Bragg gratings which are capable of simultaneously measuring plantar pressure and shear forces. This is achieved by reflecting particular wavelengths of light and transmitting all others, in this case temperature and strain variation. In their testing, they embedded a sensor in resin that was sensitive to plantar and shear forces, and in their simulation they are able to design the optimum sensor structure for accuracy of this measurement. When testing the results of applying vertical and horizontal forces, they reported that the response and measurement of accuracy of the sensor cells was high, with negligible hysteresis. The insole was designed using a 3D printer with 4 sensor cells at key points of heel, 1st MTP joint, hallux and 4th and 5th MTP joints, and 1 temperature sensor to evaluate the sensor cell's temperature stabilization time. The signals from the insole are acquired by a portable interrogation system which translates the data into plantar and shear forces and then sends it to a mobile app designed for smartphones or tablets. This app provides the analysis of the values and develops real-time results and statistics. The second research study is from a 2022 paper by Wang et al. This reports on the development of a system that they call SLIP system, referring to shear load inductive plantar sensing. Unlike the first study, this insole has 64 triaxial force sensors measuring both pressure and shear load across the whole plantar surface of the foot. And the tri-axis force sensor improves on the single axe sensor capability of the first study. This system comprises the sensory insole and a wearable data logger that transfers the data into software for calibration, analysis, and visualization. The triaxial load sensors, which they refer to as nodes, are the basis of the slip sensing array. As can be seen on the slide, it is arranged through 4 layers. The data locker system is configured to control the acquisition of the measurements from the insole and enable recording and storage of the data, which is then transferred to a PC via USB. This paper included a pilot study to evaluate the efficacy of recording in-shoe plantar loading in healthy participants. The study included 3 participants capable of unaided walking with no comorbidities associated with the mobility of foot or foot health. The participants walked 10 metres between clearly marked locations on a level floor at self-selected pace. The data was analysed with shear and pressure forces assessed in the forefoot, midfoot and rear foot. They found that the sensor at this stage of development had an error of 4.8 to 6.3% in shear force detection and 2.1 in plantar pressure detection. This pilot study showed the potential of this system, but they did note that it needed further development to manage the harsh environment with repeated in-shoe plantar load measurement. The third research paper, published this year by Tang et al., describes a further stage in the development of measuring the in-shoe multi-directional stresses. Their system is called TRIPS, Triaxial Pressure and Shear Sensing System. The sensors measure real-time shear stress in 2 orthogonal directions, which would not only allow measurement of unidirectional gait, showing braking and propulsion phases, but also potentially be used to study balance in the medial lateral and anterior posterior direction. The sensors are 1 millimetre in thickness and are flexible, and the insole containing these TRIPS sensors had them positioned at the heel, 1st and 5th MTP joints, and under the IPJ of the hallux. The insole is connected to a data collection hub where the signals are processed at 100 Hz and the results stored. The hub can be directly attached to the collar of most footwear, allowing ease of use for daily wearing of the patient. The data is then transferred wirelessly to an external device, again as a mobile phone or a tablet. The research again included a pilot study, this time using 1 healthy male with no lower limb injury or known walking problems. He initially walked for 5 minutes in a sports shoe with the insoles to become comfortable, and then was recorded walking along a 28-metre corridor at self-selected speed with his walking cadence being recorded. The process was then repeated with him wearing a pair of casual shoes that would be available in a retail store and a therapeutic type shoe which was designed for people with diabetes that had a 4-foot rocker angle of 20 degrees. The walking cadence was repeated in these shoes using a digital metronome to ensure consistency. Mean peak pressure and shear stress were measured at the 4 locations while wearing the 3 types of footwear. Not surprisingly, the lowest pressures were obtained over all locations when wearing the sports shoes, compared to the values obtained with the therapeutic and standard footwear. The shear stress were reduced by 75% in the medial lateral shear and 82% in the anterior posterior shear in the therapeutic footwear compared to that of the standard footwear. This may well be explained by the effect of a rocker sole profile. He's upstaging me, isn't he? Interestingly, up to a 40 and 61% reduction in the medial lateral shear was revealed when wearing the therapeutic footwear compared to that of the sports shoe at the heel and hallux respectively. A further study of 5 participants, including 3 males and 2 females with diabetes at risk of ulceration, was tested at a self-selected pace along a 50-metre walkway, wearing the therapeutic footwear with and without the sensor insole. This was compared to plantar pressure data that was collected using an X-sensor system at 50 Hz. Here again, there was some variance in pressure readings between the TRIPS insole and the X-sensor system, the effect between individuals and regions of the foot varying within gait. The authors recognised that the small and fixed sensor locations may have influenced the step-by-step variability in the TRIPS insole, causing this variation. And while we have to understand that while recognising the limitation of all of these systems that need to be addressed before they become able to be commercially released, it shows that the measurement of plantar pressure and shear stress under the foot is possible and not in the too distant future. While there are many ways to measure plantar pressure, the gold standard when designing offloading orthotics and shoe modifications is in-shoe pressure measurement systems. The challenge has always been that the shoes needed to be worn to acquire the data can substantially influence the results of that data. A company in Germany addressed this problem some years ago by creating shoes that were neutral as far as the effect on function. These were tested in a 2014 study by Kluger et al., which found that indeed this was the case. They did not affect function. A further study in 2017 by Hotfield et al. Validated the use of neutral shoes when using an in-shoe system. It seems, surprisingly, up till recently, that these neutral shoes have only been used in Germany and surrounding countries like the Netherlands, but the X-sensor company in Canada is designing protocols using these shoes so data acquisitions and analysis can be standardized around the world. The aim is to gather data from similar pathological conditions so that research can be easily done on large patient populations, benefiting our understanding and ultimately our diagnosis and treatment strategies. I should mention at this stage that X-sensor consults me for their clinical development of their software and information that practitioners require on plantar pressure in their daily practice. The X-sensor software has an automated area of interest feature which allows a practitioner to immediately see any area that is loaded with more than 200 kPa, which, as we know, is the key threshold research has provided. We can also see the integral timing of that loading, or integral pressure, which in some cases can be more important than the actual load amount, as it can lead to tissue degeneration and injury as the prominent surfaces are pushed into the ground, resulting in localized areas of hypoxia. The efficacy of interventions such as offloading, padding, pre-made footwear with Rockasole profiles and offloading insoles can be immediately seen through the comparison of subsequent recordings. This is a good example of the new direction of plantar pressure analysis software, automating and making things easy to understand and providing the practitioner with information quickly. The center of pressure trajectory, fluidity and velocity are key indices for analysing the complex interaction of neural, muscular and joint complex function in gait. Through analysis of the centre of pressure, we can recognise departures from values provided by normative databases that would indicate and help pinpoint the cause of the dysfunction in a biomechanical point of view. This may also alert us so that we can better predict conditions like early Charcot's. The value of this was shown in Bolt's 2018 paper. This dysfunction happens so fast it can be almost impossible to see by the naked eye. This is real-time information, so it's immediately available to be analysed by the practitioner and compared with other indices such as the pressure loading of tissues, the force versus time graph, and all areas of loading within specific anatomical areas, fully reported in numerical values in the statistics window. At the end of the day, the most important thing for any technology is to assist our knowledge and understanding so we can diagnose quickly and accurately, providing the best outcomes for the short and long term for our patients. Thank you.